Well, good morning. Well, thank you. And on behalf of our panel, thanks for having us. We are thrilled to be here. Our topic this morning, we're suggesting, is how to explore and understand how we can make our children's hospitals more competitive, more valuable, fit into the Zeke Emanuel ecosystem that we've all heard about, which sounds daunting along many dimensions if you're a highly specialized academic hospital like most of our children's hospitals are. So we have a panel with us. I'm going to ask that we go around and have a brief introduction from each of our panelists, and then we'll launch into a few structured questions, but we're going to encourage you to ask questions. We've got a little glare here, so just move your hand left to right, and I'm sure we'll be able to pick you out, and we can have some interaction. So with that said, I'll start maybe with Sandy, and we can just work our way back this way.
Great. Well, good morning, everyone. Thank you for coming back a second day. I'm Sandy Fenwick, the president and CEO of Boston Children's Hospital. You've heard a lot about us, so I will not take much of the time. I hope after listening to Dr. Emanuel, you're not looking at 4 dinosaurs sitting down here. Thank you.
Good morning. I'm Jim Schmerling, the CEO of Children's Hospital Colorado. We have 593 licensed beds, which after hearing Dr. Emanuel may be 300 too many. I'm a little nervous about going back and saying we're going to have to close some beds. We do have 17 different locations around Colorado and the region, and have telemedicine and clinics across the 4-state region, and then have patients in 48 different states. So it's a large organization, and we are working very hard. I haven't read Dr. Emanuel's book. I'm going to, but I think we're on our way in being consistent with some of the recommendations that he's made.
Hi, everyone. Good morning. My name is Muna Talak, and I'm CEO from Latifa Hospital. It's actually not in the United States. It's in Dubai, United Arab Emirates. And I thank Sandy for inviting me, actually, to come here and be with you all today. I think it's a great opportunity. I'd like to share our experience as well. My hospital is a women and children 345-bed hospital. And after hearing Dr. Emanuel's talk, I think I'm going to purchase that book as well today.
So I'm Michael Fisher, and I'm with the Cincinnati Children's Hospital Medical Center. And Sandy, thank you for hosting. And I think the fact that the 5 of us are up here together already gives you a signal about a collaboration and partnership that I think permeates pediatrics and the innovation that we hope to do together. A little bit about Cincinnati and Cincinnati Children's. We're a metropolitan area of about 2 million people, and we sit at the nexus of 3 states. And our institution had about 1.2 million patient encounters last year. Over the last couple years, we've had patients from all 50 states and over 50 countries. We have an enormous research enterprise, and later next year we'll be opening about a 500,000 square foot clinical sciences building, and we do a lot of things with our colleagues up here and look forward to talking more about it. One more thing I would say, Mark, just because it I think is representative of a part of how we work together and what we're all here for, which is kids and kids' health. And it was really a very special gesture, although I did not like the outcome of the game. But a couple weeks ago, your New England Patriots hosted our Cincinnati Bengals, and your cheerleaders wore a jersey of one of our players. Your owner made a very significant contribution to fund pediatric cancer research in honor of Devin Still and his wife Leah, and with Dr. Emanuel here, who happens to be getting her care at CHOP. And I think the fact that we work together that way to find cures is really what this is all about, Mark.
Okay, terrific. So our hospitals are in competitive systems. The United States, as you've heard Zeke go through, is a competitive model. And while we talk about the 20% uniqueness we have, Zeke is suggesting 80% is commodity services. So it suggests to us in a high-cost mission with large numbers of children that we have to be fairly innovative, and we have to create and reinvent the next iteration of our care and technology. So what we'd like to start out with is just a discussion of how we're doing on that, what we have made headway in, where we're creating more innovation, where it's made a difference, where it hasn't, and go around. And Michael, maybe you could continue on your last discussion and get us started.
So maybe just a couple quick things I would use by way of an example of some things that are innovative that we're doing that speak to some of the collaboration, some of the culture, some of the investment. One is right now we're in a phase 1, phase 2 trial phase on a gene therapy treatment for sickle cell. And I think what strikes me about that one is A, recruiting great talent and developing and nurturing them. B, having collaborators inside our institution to work with across a range of conditions and diseases. 3 is some physical infrastructure like a gene vector manufacturing center. So that'd be one quick example. Another, and I think Dr. Manuel spoke about mental health toward the end. 3 of our colleagues, in conjunction with some people with the Mayo, developed a gene test that helps figure out the right, the right treatment, the right dosage around, neuropsychiatric kind of disease conditions. And that has spawned a company called Assurex, which here in the last couple years now has over 200 employees. It's performed 100,000 plus tests on patients and has attracted $30+ million in venture funding. And I think how and why does that happen in a place like ours? Well, I think it starts with a board and leadership from day one who said that, as Zeke indicated, that discovery, research, innovation is what's going to keep places like us thriving. And it is what we need to be able to bring to patients. So I think it started with that. It started with some philanthropy investments many years ago, frankly. And then it's enabling structures. So we've got a Center for Technology Commercialization. Physically, the way we've set up our campus, bench to bedside is not just an idea. It physically is the way things happen in our place. So I think, Mark, those would be a couple examples of the kind of things we're doing.
Sure. Well, lessons from Dubai. What have you been working on there?
Okay, so just so that people I'll tell you a little bit about Dubai first. It's an emirate in United Arab Emirates, and one of 7, headed by a very strong and visionary leadership by our president, Sheikh Mohammed. And just a couple months back, he actually started an initiative which was it was a brainstorming session for the entire country. It was for people to for a whole week to drop in their ideas, their suggestions and feedbacks about healthcare. So what he wanted really to know is, areas that need improvement and change and innovation, basically. And that was very useful, and then it was categorized and basically distributed to the appropriate people. So our work mostly has been around patient experience and patient journey. And what we have done is we have almost every few months where you have key leadership people in the organization, Dubai Health Authority, which Latifa Hospital comes under as one of the public or government hospitals, is that we go on air for 2 hours, and this is to listen to people and have access to them to tell us about their suggestions and feedbacks and ideas. I think we're in a time where to be competitive and to survive, we need to know what people want. And the only way is to listen to them and be available. I think the first remark that was made that you rarely get to see CEOs, in part that might be true because you're just in your office doing your work, but to be available and to listen to people is very important. So I think that's one of the areas that we are heavily working on. And we've found that with e-suggestion, e-government, government actually takes a lot of lead in this, where we have systems, we've created systems where people, anyone it could be patient, parents, healthcare providers, where they can put their suggestion or their idea and it gets sorted out at government level and then distributed to the proper channel to be taken care of.
Terrific. So you've talked about innovation from a standpoint of engagement of your communities. Michael mentioned a little bit the science edges. Jim, do you want to put a cap on any of this?
I'll save the innovation from a discovery standpoint. Our Department of Pediatrics, I think, is the 5th highest in terms of NIH funding, but some of the innovation that's coming from Children's Colorado is in developing an integrated delivery system. Rather than being just a single institution, we have this distributed system now with the satellites, and 650,000 outpatient visits compared to 18,000 admissions, and we're pushing as much of the care outside of the hospital as we can. With physical facilities in a 200-mile radius, and then telemedicine going even beyond. So a lot of the innovation is in that delivery system, but we're struggling, as most of us do, with the reimbursement system. So the more we push out, the less revenue that comes in, and we're getting constrained. The top-line revenues are really being pressured. Half our patients are Medicaid, which makes it even more of a struggle. So our innovation is looking at how do we change not only transforming the delivery system, but transforming the payment process as well. And working with the state of Colorado, maybe we'll talk more about the ACE legislation around the changes we'd like to make and taking some risk with chronically ill children and allowing children to cross state lines and have consistency in their benefits and the payment structures. But our innovation really is coming around the delivery and then the payment that comes with it. One without the other is very difficult.
So it's clear innovation's taking a lot of different forms. Sandy, did you want to just comment briefly on organizational development or innovation around organization? Because clearly Boston Children's has been an interesting working process for many years, very complex faculty, very interesting scientific arrangements at the school.
So obviously, one of the most important things that you've heard, I think, over the last couple of days is that we've got a long history of being an innovative organization. As I think Kevin said this morning, it's in our DNA. And the most important thing I think that we have had to do is to encourage that, given all the challenges, the funding challenges, the need to reduce expenses in the institution, to look at competitive issues in our marketplace, to grow our delivery system, all of those things. The question is, how do you make sure that you really don't take your eye off the support of everybody who is an innovator in the institution? So I think the first thing is, are we absolutely looking at this as everyone at the institution is an innovator? Everyone has really got a great idea, and how do we allow those to bubble up so that they get exposure, they get support, and they're supported at every level, from the top down, from our chiefs, from our leaders at every single department. The second thing is, are there opportunities to really support those ideas? Can we make sure that when people have ideas, they have a forum? You heard from Naomi Freed, our Chief Innovation Officer, yesterday, that we really have tried to create forums for people to come forward, not just to bring their ideas forward, but to learn from others and how do they advance those ideas. I think the funding of them is a key component. We've put a number of different things across the spectrum, from the basic science to a translational research program that supports great ideas, great investigators, to clinical research and clinical trials, all the way through the very interesting different kinds of innovations around patient care, digital health, information systems, and the like. So it's truly the whole spectrum. And I think it has spawned philanthropy. Michael, you talked about philanthropy. I think when philanthropists see that there is just exciting opportunity to address the things, Mona, that you talked about, from patient care to science, I think it also encourages an enormous amount of support from the community, which really is sometimes the most important thing to actually generate and ignite some of these ideas. So it really is a multi-pronged effort and strategy, and requires the support of everyone to encourage.
So it's a good transitional comment. We've talked a lot about culture and the need for culture to support the kinds of things we do. The old saying about culture eats strategy for lunch, I guess, which is pretty commonly bandied around. And Jim, if we could kind of continue your Colorado experience, what have you thought about or tried to do or foster in the broader culture and inclusive of your whole campus? Because you're sitting in the middle of a complex enterprise.
Well, Children's Colorado, unlike Boston and Cincinnati's history, is a relatively new academic medical center. We formed our affiliation with the University of Colorado School of Medicine in 1990, and so the relationship is relatively new. And so the work around innovation and discovery culturally is taking some time. So we have had a number of discoveries that have come out of Children's Colorado. I go back to nitric oxide, which was developed by neonatologists at Children's Colorado, and we shared it with the world. Another company came in and licensed it and now sells it back to us. And we spend over $1 million a year, and so it's been millions of dollars that we've paid to buy back our own discovery. And so changing that culture to say it's great, we want it to encourage discovery, but one way to help fund that is to monetize some of those discoveries. And so we have started with basically a small venture capital pool that the hospital is supporting that will try to monetize 2 or 3 of these discoveries every year and take them out into the market. And we just did our first 2 in 2014. And hopefully we'll be able to talk more about those next year, one in pulmonology and one in GI. But that's a very different shift, and it's actually catching hold because the faculty see that they can bring in revenue streams, potentially, to fund their ongoing research and activity. The other thing that we're doing is around philanthropy. We're trying to create a research institute that would be funded with some large gifts and are getting a great deal of traction. I think the community does support the activity that's taking place at the hospital. They see that as an investment. And when we're investing in something that has social good along with a potential return, it's very attractive. And so we're new in that discipline, but we're finding it's catching on. But part of this is getting the faculty to realize that this is a great way to get some, not only acknowledgement, but to fund some of their activities.
And is there any engagement of the faculty that you found particularly effective or strategy you've used to move this along?
Money works. As it's getting more and more competitive to get research and they're feeling that squeeze, I think they're realizing, and then when they lose a grant or the grant expires and they need bridge funding for the next round, they're realizing we've got to get more creative to continue their tremendous work. And I agree with Sandy that we want to encourage this at every level. Our board is engaged. Research and discovery is one of our 5 key strategic priorities that the board has approved. We give them updates at every meeting, so it is from the top down, giving them a level of support, and that gives them some encouragement that they're on the right track. It reinforces the kind of behavior that we'd like to see.
Michael?
Just a quick add, I think beyond money and beyond infrastructure, I think recognition matters too. And so, we've added some awards within our faculty recognition area. We've promoted it, successes across the organization. To Sandy's point, even when great ideas come from non-faculty, we give visibility. We have a research committee of our board that meets once a month, and for a faculty to get to present innovative ideas in front of the board and other outsiders has been a big deal. And then I think to the all-in idea that Sandy spoke about, really connecting our innovators to the external community also. So we've got some pretty exciting things in terms of early stage funding, in terms of some ecosystem, public-private partnerships in our community that have exposed some of our faculty and some of our other folks to how do they get their ideas to market, how do they bring folks outside into the institution, and I think those things culturally have really turbocharged this. Difference.
Mark, could I just ask, I think the only other thing we need to add to the recognition is medical school recognition, because when you talk to faculty, one of the things that they always say is, but if I'm looking at this piece of innovation, it may not be what will really help get me recognized and promoted within the medical school. And so how do we make sure that the medical schools also recognize and support innovation in a very, very broad sense as well?
That's a great point. Michael, Cincinnati has become well known as a leader in safety, and that's entailed some cultural change relative to how you fostered the innovation. Could you spend a few minutes on what you've done there and how you've thought about it?
Sure. And I think at the risk of being a little redundant, I think we're all in these things together, and I'll maybe segue to that. I think when it comes to safety for us, the culture piece, I think the obvious piece is we never want to harm a child. We never want to harm an employee. I think for us, though, making that really explicit that the goal is 0 and the only acceptable answer is 0 really totally catalyzed how we thought about this and how we approached it. And, I think from a cultural standpoint, it is owned by the board and leadership and the frontline clinicians. It's the first item on the agenda at every meeting. We, as leaders, and I agree with you, Muna, I don't know where that introduction came from because we try to be out and about a lot with our teams and whether it's safety rounds or whatever. But I'll fast forward to say that we've been very focused on this for the better part of a decade, initially catalyzed by a philanthropic grant from the Robert Wood Johnson Foundation. And now, with my colleagues up here, we're part of, as you know, Mark, an 82 institution Solutions for Patient Safety network. And I think, again, culture things do matter. And one of the things that when we started working on this together as institutions, and I think your intro talked about us being competitors, but when it comes to something like safety and when it comes to something like discovery, we don't compete. And when we said we're going to leave all that baggage at the door, we are going to say who's got the best ideas, who's got the best processes, who can learn from each other, how do we share data to enhance that, how do we have an all teach, all learn environment. That's what this Solutions for Patient Safety network has become. And I won't get the statistics exactly right, but earlier this week I heard Dr. Muthing, who's the clinical lead for this. I think over the last 2 or 3 years, we have collectively as 80 institutions had 1,800 children who were not seriously harmed if you extrapolate where the trend lines were versus where they now are a couple years later. So you can tell we get very energized about the potential of this, and really the cultural piece was foundational to it, Mark.
Absolutely.
If I could just add one more comment to that. About 3 years ago, we had the chairman of the board from Cincinnati Children's come talk to our board because we were having a big debate. Can you get to zero harm? And we're human, we make mistakes. How do you get to zero, and is that a realistic goal? And someone from Cincinnati Children's, the chair of the board, came and met with our board and said, we are human and we make mistakes, but you can create systems that don't allow that harm to reach the patient. Those mistakes don't have to reach the child. It is possible to get to zero. Starting at the board level, telling the hospital management, we believe you can do this. And again, that's part of our strategy. And the collaboration between Children's and the SPS is several years old now, and it's been phenomenal.
Yeah, and I think there's also that partnership and the trust and confidence you got to build to take risk, to innovate is huge. And that's not just on the safety piece, it's on the discovery piece as well. Because I'm sure if we held our faculty to the standard that every idea and every experiment they had to result in a great breakthrough success, no one would ever do it because of the risk. So I think to this culture piece, when we've had a serious safety event, when we've had harm, I know that the board chair has got my back. I know I can pick up the phone and call one of my colleagues and say, hey, we had this issue. Can you provide anything your institution's doing that's different that'll help prevent it from happening the next time at both of our shops? And so I think those things are a big deal. And Muna, I would be interested as you think about safety in your country, in your culture, and in your institution. Any thoughts you have on that?
I think, we all agree that for all of us, we want, patient safety is first, and nobody wants to harm a patient or a child. And to build that culture is extremely important. In our hospital also, again, I think it's a leadership commitment, and it goes from that, there down to everybody. I remember just a couple days back, we were sitting at a meeting, and there was a question about a Sentinel event, whether they should call it a Sentinel event or not. And the head of department, or the chief of that department, was actually disagreeing on a point. So I had to make it clear that it's not actually calling it Sentinel event or not. What happened is you don't want it to happen again, and that's what we need to look at. And so building that culture is very important. And I think we still have ways to go around that. But we do have a strong leadership commitment. And here is where I think when you involve your patient is very important. And when you involve the parents is extremely important, because we can only see it from our perspectives. And when you get used to doing things the way you are, you don't see it differently. But it's when you hear others speak about it or come up and tell you that it's very important. And I believe we've opened those channels that are really, helping us quite a lot.
A general observation on these items has to do with the role of governance in setting culture. For many years, our children's hospitals and most academic medical center systems, boards worried about the finances, they worried about finding a CEO, medical school relations. But Boston Children's, I think early on, had quality on the board agenda. Cincinnati's had safety. And so we're seeing, I think, governments putting their arms around some of these bigger topics as kind of mission-critical topics, as important as things like, are we solvent from a financial standpoint? We did want to spend a little bit of time on collaboration and then perhaps open up for some questions or Q&A. The children's hospitals have been pretty famously collaborative, in part because there are fewer of them. They are somewhat less competitive with each other than the adult hospitals, only because we've got over 200 million adults in the US and somewhere north of 70 million children. We do want to talk a little bit about collaboration and how we could do that more or better. And for those of you in the audience who are in the biotech or other sectors, we'd be really interested in your thoughts about how the hospitals can actually do this better. But I wanted to start a little bit on the collaborative track. Maybe we can start with Jim.
Sure.
And spend a little bit of time on how we can accelerate, do more of that.
I'd like to give two examples. The first around family involvement and the board. We had a patient who died as a result of an error, and we invited the mother to come and talk to our board. And someone asked, what can we do now? And she said, share this experience with other children's hospitals so it doesn't happen to any other child in this country. We came back, and there is a patient safety organization that was created at Children's Hospitals Association, and we had minimal participation. But since the advent of the safety patient program, more and more of those hospitals are participating in it. It was at 30 or 40 hospitals now that are in the PSO. And so when we have those types of unfortunate experiences, we share them with one another so that we can learn and prevent that from happening in any of our institutions. That type of collaboration is making a huge impact on children across the country. It's critically important, and we couldn't just do that by ourselves. We'll learn from other institutions and hopefully not repeat their mistakes. The second level of cooperation and collaboration that I think is going to be even more prevalent, it comes back to this delivery system. While Children's in Colorado is looking at its 3-state region, and in Cincinnati you've got the Midwest. I'm not sure in the Arab, in the United Emirates, but we're going to be looking more across the region and nationally, creating networks. We're working right now with TRICARE. The children who are dependents of active military get moved around a lot. And when these kids have cancer or some chronic disease, it's very disruptive. Either they have to start treatment over when they relocate, or their transfer is delayed. And so some of the active military actually are impacted, their careers are impacted because they're not moved to another place because they're in one institution. We're working with the Department of Defense and trying to create, through TRICARE, what we're doing in Medicaid and creating a national network of children's hospitals. So when these children, these families get moved, we can move their care seamlessly. Where if we're not all on Epic or what Cerner, I'm not sure, what are you guys on? Cerner. You're on Epic. There you go. We've got to have somehow some mechanism of integrating our data so that we can have a seamless transfer of care and not start all over again, but keep these children on the same protocols, have some consistency and standardization, particularly around the chronic and complex conditions that we're managing. And that type of collaboration is going to be critically important as we go forward. The state barriers are going to be removed as we go forward.
Any thoughts about collaboration? You're our international broad-based place today. I mean, how do we do more things between countries? Is it useful given the difference in payer systems, or what are your kind of views on this?
I believe it's actually very useful because although systems might be different, payment systems might be different, but at the end you have patients and you have kids that are sick and you want to do better for them. So sharing knowledge, experience, expertise, I think is very important. We heard yesterday that, some of the challenges that especially the pediatric population has is about rare disease. And with 7,000 diseases and only 400, treatment, do we have enough number in one place? I think unless we share this together and work and collaborate, that's the only way to go forward. So I really believe that that's very important, actually.
Yeah. Sandy, thoughts on collaboration?
So Michael mentioned before the gene therapy trials that are going on, and I think that this is a perfect example of not only how we have collaborated between Boston Children's and Cincinnati, but also in France, in Germany, and in England. And we are, it is critically important, Muna, I think you're absolutely right, especially as we as children's hospitals deal with rare diseases. The numbers are small, that the challenges are huge, the funding is challenging, And so how do we not only, and Michael, you talked about how you've created, a whole ecosystem within your organization to support that. But then we've also, I think, taken it a step further and really moved it to an ecosystem that is now not only national but global. And I think it's just a great example of how we are leaning on each other and learning from each other and working on some of the challenges that if we tried to do this, given the small numbers and the high cost, we would not be able to make much progress on.
If I could add maybe just two items, and I mean, this is terrific learning for me, but I think just building on the international and sort of how do you get complementary expertise at the table to get something better. So we've got a substantial pediatric surgical program, and yet the pace of development of new devices for children when it comes to surgery and surgical conditions has not been particularly robust. And so we developed a relationship with Ben Gurion University in Israel, who is world-renowned for their engineering expertise and commercialization of that, and partnered with them, and we've got some pretty active and good ideas coming out of that, and I think it's an example of. And then I think with industry also, and I know probably there's been a lot of discussion yesterday and today on pharma and other biotech kind of industry, but even something in our case, I'll give an example, and Dr. Manuel had it in one of his slides. Toyota, we've had a 10-year collaboration with Toyota on the proper installation and proper use of car safety seats, and research associated with that, particularly in the Hispanic and the African American communities. And talk about saving lives. This is now, I think, 10 or 15 cities. But sometimes we get excited about the sexy innovation in research, but I think we know, back to Jim's point about the clinical delivery system, there's so much we can do to improve the lives of children that doesn't require the next great breakthrough innovation.
So we've spent some time on innovation and collaboration, culture. You do have 4 CEOs here. They're from everywhere from the Rocky Mountains to the East Coast and Dubai. So what's on your mind? Anything you want to talk with the panelists about? I'll start with Charles, and then we'll go up into the corner.
We've heard a lot about the intersection of innovation and risk. Many of the institutions here are not-for-profit. Many of them have budgets that are very stressed each and every year. How do you make decisions about potential innovations that don't have an apparent return on investment?
You knew you had to get it.
It works for me.
You want to go?
That's tough.
Leave it to a Bostonian to send an easy question. Jim, do you want to take a first stab?
No. But I'll try. We actually have return on investment. We define it not just monetarily, but what is the benefit to our patients. And so if we do have a very collaborative process with physicians and executives that look at 100 proposals a week, all great ideas. In fact, I get teased because they know I've never heard a bad idea when it comes to trying to do something for children. So somehow you do have to tease out and prioritize. And so there are a number of criteria. One is, what is the overall impact? How many children will be affected by this? Is it something that we can do and that can be replicated and spread across not only our organization but elsewhere? What is the financial investment? Certainly money has to be a part of the equation. And what is the budget that we have, and how would we prioritize that? But it's an iterative process that we go through with a number of our faculty and senior executives together. We're also a nonprofit with a very small margin. And so you do have to weigh those things. But many of the ideas, if they do have an ROI, it's 5 or 10 years out. And so that can't be the only criteria. We wouldn't get anything done.
Can I just say one quick thing? It's really the mindset of we're a not-for-profit. And I think increasingly, and again, I think the presentation preceding us speaks to the notion of needing to be competitive. And I think, somebody once said to us, which maybe isn't that new of an idea, but, not-for-profit is an IRS designation. It's not a business strategy. And I think, for us to leading institutions and have them be impactful, we have to think comprehensively about all the levers. Risk management is certainly one, but if you don't take some risk and you don't innovate, you won't be around for very long.
That's what I was just going to add. we have to figure out how to look at the risk component, not just the reward component, and understand how much risk are we taking, and can we manage the risk with the upside of all the different components of return. And so, I think yesterday, I think it was Carlos who said, or maybe it was Bill who said it earlier, that sitting on the sidelines and not taking risk is the riskiest strategy of all. And so I think we have to figure out how do we take some of those measured risks, help people identify what they are, how long-term they are, when you can get out of a potential opportunity or an investment, but also how you weigh all the other components that go along with that.
So Charles, you got more out of that than you thought. We had one question up there, and then I'll come back down here.
Thank you. So we've heard a lot about the ways you can positively benefit innovation, but I'm curious to hear your thoughts on what you think some of the systemic barriers are. For example, yesterday, Dan Nygren referenced some of the legal hurdles to innovating among medical informatics. And in our rare disease section, we talked about some of the regulatory barriers to new drug development. And so what do you see as some of these barriers and ways to overcome them? And then maybe after Muna, you could mention how your system is different and what we might learn from that.
Sandy, you want to go, Muna? So I think some of the barriers, Sandy already signaled. I mean, I think whether it's, faculty career tracking could be a barrier. At times, funding can be a barrier. At times, risk management or some of the infrastructure, so the speed of your IRB, the connectivity of your IRB to others so that we get the critical mass that Muna talked about to have a robust trial. You guys could probably fill in the blank of 10 more barriers. I think in terms of what we're doing, and again, I think you've already heard us signal some of the things we're doing. I mean, Sandy talked about institutions like ours working together on some research things. So we're exploring some things about how we could do those things together. We've done some of that with our peer institutions in the state of Ohio so that we can really accelerate trials, which we're doing right now in the area by way of example, asthma. On some things. So I think there's things like that. I think getting boards and philanthropists to provide early stage and seed funding, which we're doing across the continuum, again, as I think Sandy and Jim and Muna signaled. And I think on the education front, to our board, we have a spotlight at our audit committee once a quarter on enterprise risk. But I think the more they get educated about what it is and what we're doing to mitigate it, it takes down the temperature of being willing to consider more as long as it's prudent. So those would be, I think, a few examples of things we're doing.
A question back for you. What do you think the hospitals could do more, better, or different in this area?
I'd hate to say. I'm actually, these are all very inward-looking things that we can do locally, but do we need to have more of a political approach to matters? What about social questions and lobbying, legislative approaches? And how is the American system different than, say, in Dubai, where there's a very different payer system? There are a lot of constraints, obviously, imposed by our third-party payer system here in the U.S.
Right. Actually, talking about Dubai's experience, so in Dubai we have more than probably 100 nationality actually living. We have people from everywhere. And it's a more of a social medicine, so where, government is basically taking the brunt. We do have the private part of it with the insurance, but majority is actually very social medicine. Now, our challenges or the barriers that we've had is, again, having the expertise dealing with, with some cases, special cases. So what we've done, maybe funding hasn't been a big problem for us, but we've partnership with other institutions, for example, in UK or different countries, to build and collaborate and work with them on research and cases that are specific to our area.
Okay, terrific. Yes.
Hi, my name is Leslie Wainwright, and I'm from Avia. And I have my question, it might start with you, Mark, and then the rest of the group, is you've talked a lot about commercialization as a vehicle or a lever to take a lot of the work you're doing internally and monetize it and deliver value out. There's also so much venture capital and so many new companies that have the combination of health, well, you can take 10 words and come up with 100 company names that I'm sure are bombarding all of you, more early stage companies. How do you get over that not invented here syndrome and also lever and take advantage of so much of that external entrepreneurship that's happening and bring that in? And I'd love all your different perspectives on that.
No, I'm happy to make a general comment about it. I do think the positives of our system in the United States are that we've got really brilliant campuses and great schools and great human capital attached to them. We are afflicted with a not made here mentality that runs in streaks. And you can see this, and we're also discovery people. Most of our children's hospitals are academic medical centers. They're into discovery. So every CMMI grant, every NIH opportunity is another chance to create another repository or another pod of data or a pod of activity that's different from the existing pods. It might be a slight improvement or a slight difference. So one of the things that I would suggest as a challenge for us is to differentiate ourselves as a collective. So as a sector of children's hospitals, whether it's the safest hospitals in the country, the ones that are best environments for kids, but that will require that we kind of think about the balance between discovery and innovation and uniqueness on our campuses, and actually agreeing on a few things we might do together, even if it wasn't invented, here in River City, which I think is one of the things.
You should talk about the medically complex patients that we've all been working on together.
So the quick addendum on that. So we've got a bill in Congress, in the House of Representatives, what we call the ACE Kids Act, and it is an attempt to create a unified national network of delivery systems for medically complex kids, which is a small number of children. They fall into Zeke Emanuel's very high utilizer category, and many of them travel over state lines since we've got 50 states and probably only 30 or 40 really large children's hospitals that are regional centers. Right up in here in New England's a great example, right? If you go north of Boston Children's, you run into 3 or 4 more states, but not more Boston Children's, so kids have to come down here. So that's an example of something where we've got over 60 hospitals that are working together to see if we can get a program that's for the country. And the more we can do these things, we feel we can differentiate where we are.
One other thing I would just add that maybe gets to your question around how do you change that culture of and welcoming not invented here, and something we're doing, and the returns are not in yet, so I can't say definitively, but, and Jim and I talked about this a year or so ago, we just hired a senior vice president for strategy and growth from the Procter & Gamble company with a Gillette pedigree as well. And so A, not healthcare. B, one of the things that Procter did to really turbocharge their business was what they call develop and connect, which was they used to always think they had to come up with the next Tide. Every product had to be created from their pipeline. And they, about 10 years ago under Mr. Lafley, said, let's start finding those early stage ideas, those great entrepreneurial companies, and invite them in. Let's partner with them. Let's give them help, et cetera. So Jennifer's off to a great start. She's partnering with our head of our research foundation and chief medical officer, Dr. Peggy Hostetter, and I'm pretty excited about what they're going to do to help change that culture.
We have the president of King Soopers for Colorado. King Soopers is a part of Kroger. And he came to us and said, we're going to create primary care in our grocery stores, in our supermarkets. Would you like to do the pediatrics? And the pediatricians in our community said, if you do that, we'll take all of our admissions somewhere else because that competes with us. And so we talk about barriers. Our own referral sources are saying, don't go there. They're taking over our practices. And so over the last 2 or 3 years, we're working with those pediatricians to say, it's here. We're not going to stop this. How do we participate and get at the table? And because it is a competitive threat to those pediatricians, but we see this as inevitable. And when you look at the list that Dr. Emanuel put up of all the different alternative deliveries, organizations that are coming in, whether there's freestanding emergency rooms or the Walmart and King Soopers primary care, we have to be a part of this or we get left out. I'm from Nashville, Tennessee, and we'll never forget that the recording industry went crazy over people's ability to download music. And if you recall, they were suing college students from downloading music because it was affecting their revenues. Rather than say, how do we get in on this, They tried to stop it. You can't stop these things. And so I think our best strategy is how do we participate and become part of it?
Yes.
Just getting back to more of the internal questions, all of you are leaders of very complex organizations, and you have a very heterogeneous group with you. You have faculty that are in academic positions. You have administrators who have different career paths. How do you align those, and what's your strategy to align those, and how do you inform people of what your priorities are as the leaders of the enterprise?
Muna, you have the most heterogeneous group to align. Could you give us a sense of how you think about that?
Okay, I think, I think priorities, should be there, and aligning them and aligning your strategy is very important to be able to execute them, actually. So basically, for us in our organization, it's actually patient safety and quality is top priority. And everything else has to come around that. So yes, we want to innovate, we want to advance, and we want to do better, and we want to be cost effective and everything else. But it has to all come to patient safety and quality. So we cannot compromise on that. And I think once you make that very clear in your, in your board of management, then everything has to be related to that. So that's how we actually do it.
Okay. Up at the top, and then we'll come back down to the front.
Hi, my name is Misty Witt, and I'm with Action Products, and we're actually on the manufacturing end of the spectrum of the group here today. And I was glad to hear a little bit of conversation about medical device development. I think, Mr. Fisher, you noted that there hasn't been a lot of activity in the medical device realm for the pediatric population, like right-sizing products. And I was wondering if you might comment on the opportunities, all of you, that you see for medical device development specific to the pediatric population.
So a couple of things. I think back to the culture thing, you're welcome to call me Michael. I suspect Jim and others would say the same. And I don't know that I could dimensionalize the market size for you. What I can say, and this gets back to the way Jim answered an earlier question about ROI, for us, if there's ways to come up with devices and other tools that will improve the health of children, you're going to have enthusiastic partners to help you explore how to do that. And so that'd be my high-level comment. And just to say that, the proverbial, you can't just miniaturize something that's done for an adult. And so I think really building the relationship and the connectivity with our surgical teams and our institutions to help you get more insights into, what some of the needs are, where some of the problems are, would probably be fertile ground for coming up with new ideas.
If I could just, Sandy and I were talking yesterday about a grant that Boston Children's got around the medical devices and how the funding and the vendors are looking at this. I thought it'd be interesting if you could share that.
Sure. So, I think one of the real opportunities is to try and get, first of all, I think philanthropists to say there's an opportunity here, because many times the market, as we all know, in pediatrics is very small. And that's usually one of the biggest barriers, is you can't entice companies, particularly in device, but also in pharma and biotech, because the market is really small. And so I think first and foremost, we need to figure out how do we support the initial development of these to get them to a stage where there is something that really can be taken to market. Then the second thing is, how do you bring together a whole group of both companies and vendors to see if there's a way that you can actually entice them to be interested, even if it's only a very small portion of their business. And I see Don Lombardi here, who has been, I think he was just going to ask a question, or maybe give an answer to that, because Don is somebody who has been trying to actually bring vendors and VCs and angel investors to the table. Is that what you were going to say, Don? I saw you were going to...
How'd you know, Sandy?
I saw you with the mic.
Yeah. Thank you. Yeah, I just wanted to say, I think the I've been looking at, as Jim and Mark, Noah and Sandy, I've been looking at this issue for a long time, since the 90s, and there are two or three parts to this. I think one is that the return on investment for the initial, even finding out what's needed and doing the early stage developing of a product concept, there's very little incentive for the for-profit investor or companies to even invest in that early front end of the innovation process. And I think it does require a community to do this, and that there are so many products such as reformulated drugs and basic patient care devices that our clinicians are looking for. I think in addition to leveraging people resources and some dollar resources that don't require return on investment, I think there's a very interesting need to see how we can justify the expense of these products, not so much because it's cheaper and it's going to reduce your supply chain costs, but it can really reduce the patient care costs. So that's an area that I'd really welcome some collaboration on how do we do that kind of outcomes research on reformulated drugs or novel devices and build the full outcome benefit into the case for pediatric products. I think that could help change the paradigm.
You know, I'll make a quick comment on this. So at least inside the Children's Hospital Association, we do have group purchasing on the order of about $2 billion of activity. It's, I think, one of our hopes that the national collaborations around safety and quality will begin to define bundles and protocols that will actually be expanded to include specific equipment, supplies, pharma that actually would be the state of the art or the gold standards. And I think in those ways, we will create bigger markets for what otherwise are small footprints, often broken into 3 or 4 pieces. It's amazing how many vendors are often in these very small markets. So some aggregation to the degree we can link it to better outcomes is actually something most hospitals can probably get behind if we can move in that direction. So we had someone in the front here or up in back? Okay.
Good morning. I'm Valerie Fleischman and have the great pleasure of sitting on the Family Advisory Council at Boston Children's. And so my question is around the patient experience. And can each of you talk about the innovations and or changes that you've put in place in your institutions around the patient experience?
You want to go first, Jim? You want me to?
She sits on ours, so I know she knows what we're doing.
We've done a small conference and determined Michael will go.
I think the fact that you have a family advisory council and a patient advisory council, as do we, I think is a signal that we understand, or growing to understand, how important the experience element is. So those are very robust. They're involved in everything we do, from facility design to consent forms relative to our blood bank and specimen bank, and on and on. So I think there's those elements. Probably like you, we've had consultants in and training to see where some of our gaps are, which are some of the proverbial mystery shoppers. We have on our executive dashboard a net patient experience promoter score that we keep track of on a routine basis. About a year or so ago, we took one of our top clinical leaders, Dr. Ann Boat, who had some difficult experience as a mom at Cincinnati Children's, and she is now leading our patient experience team. And much like the journey I alluded to a little while ago about our safety work, it started with one of our clinical leaders with a passion for safety to help drive that culture more. But I think back to Muna's theme the whole morning, I think it really is getting that voice in every discussion, in every meeting, and really working on meeting those needs better. So at a high level, that's what I would say.
We have parents involved in many, many committees. In our board-level quality patient safety committee, we have 3 parents who participate. We just had a board retreat last week, and the chair of the parent advisory group did an hour presentation to our board. And there's a very lengthy discussion about what we could be doing to support parents, to support the their input. This is a parent of a chronically ill child who's been with us for 12 years and had some terrific insights. And so we're always seeking the input of our parents.
Let me just add that, Jim. I think it's for our institution, I suspect all of ours, it's not just the parents. So we have, I think, the patient themselves. And a really good example of that for us is we do once a year a big surgical safety stand down. And we have the entire peri-op team, several hundred people in the room, from anesthesiologists, clinicians, surgeons, nurses, et cetera. And we usually have a teenage patient come in there and talk about, here's how it feels to me to be a patient who's had 60 surgeries in your institution. And I think, while it's our nature to connect with the parent, I think the more we can actually get the child's voice in the mix, I think it's really going to improve that experience.
It's a pretty cool idea. I'm going to write that down, Mike.
One last point. I think we have to be really deliberative about this. We have required of every one of our departments and divisions a quality management plan. And this year, for the first time, one of the questions that we have a senior clinical leadership group that evaluates the progress that each of these departments has made. And one of the questions we specifically asked this year of ourselves as we were going through this is, what are the patient and family engagement components of the quality and management plan? Where are they actually participating in the development of quality, and this is just one example, quality and safety within that department or division. So I think we can, as you say, you've got to bring them up through governance, you've got to bring the voice up through our clinicians, and we have to be really deliberative about not only saying that we're doing this, having the various committees, but making sure they're getting embedded in everything we do.
If we've got time, we have an infinitely patient question in the front row. Oh, okay, there we go.
So I'm actually a parent at Boston Children's as well. I have 2 medically complex kids, 100 days in hospital kind of record. I actually think you guys need to designate a frequent flyer card status for some of us. But I would really like to ask you, what are you doing? I know we participate in boards and we're parent leaders and we support things. But for the side of innovation, how are you inviting us, not just on engagement, also on the clinical innovation, the research innovation? How are you inviting us and partnering with both the patients, as you point out, and the families to really both improve your care, but improve care for all kids? Thank you.
It's a great question. I would ask you what level of involvement. We do have like a research institute committee that prioritizes the dollars that are being done for our research. The hospital funds a big pool of money and say, you guys go out and prioritize. There's not a parent participating. Would you?
I would love to. I'll move to Colorado to do that.
Come on down.
Sure.
My name is Muna. I'm also from Dubai. So I'd just like to share my experience because I've been working with Boston Children's Hospital for the last 7 years in research. However, the last 10 months I've been working with the International Heart Services. Thank you. So the last 7 years I've been working with Dr. Christopher Walsh, and it's all in the capacity of research, coordinating genetic research in the region, regionally. So in addition to being in Dubai, I travel a lot to Kuwait, Qatar, Saudi Arabia, Bahrain, so all the regional countries. My experience is research is essential and we have to encourage it, whether by providing funding, providing connections, because this will be the forum where you can encourage young scientists. There are a lot of efforts done, but not enough. And I think part of the collaboration that we're talking about is to emphasize about research and about allowing also training in these areas, whether it's clinical fellowship or research fellowship, or even there are a lot of requests for actually residencies, how to open these doors for these young doctors to come here. So I think this is one of the areas where we can advance collaboration between developing countries and here.
Great. I think we agree, and I think we're doing it and going to do more of it, and we could maybe talk offline. I did want to come back to the family and patient involvement in research. So just briefly, There's these things called the PCORI grants, patient-centered outcome research, and we've got patients and families daily inputting their ideas, their input, their experiences into the research that we think is going to be high impact.
Thank you so much, the panel. Thank you for sharing your vision and the challenges that you face. We all appreciate it. Thanks.